Welcome to EduSM. Our learning objectives. We learn the definition of RSI, its indications, and as well as the 7 P's. Enjoys. Rapid sequence intubation is the administration after pre-oxygenation of a potent induction agent, followed immediately by a rapidly acting neuromuscular blocking agent to induce unconsciousness and motor paralysis for tracheal intubation. It is based on assumption that the patient is not fasted. RSI is meant to reduce the risk of aspiration. Positive pressure ventilation is not suggested to minimize aspiration. What are the indications for intubation? You have to ask yourself 3 questions. Is there a failure of air maintenance or protection? Is there a failure of ventilation or oxygenation? Number 3, what is the anticipated clinical course? Remember, gag reflex has no clinical value to assess for the need for intubation. It is actually better to assess if the patient can swallow or not. Pooled secretion in the mouth may indicate failure of airway protection. Simply the patient is breathing does not mean the airway is preserved. When the airway is compromised and it is not immediately reversible, you must consider intubation. There are 7 P's in RSI. First is preparation, number 2 is pre-oxygenation, number 3 pre-treatment, number 4 paralysis with induction, number 5 positioning, number 6 placement with proof, and number 7 post-intubation management. Preparation is the most important thing that you do even before RSI. Even before the beginning of your shift. I usually remember it as meals, M-E-A-L-S. M stands for mask and medication. You have to have all types of masks ready. Nasal prong, face mask, back valve mask. M is also medication. Have your pre-medication, induction and party agents ready. E stands for ET tube. 8 for males, 7.5 for females. Make sure you have one extra size bigger and smaller than that. Make sure it's functioning and not leaking. A is adjunct airway. You need your OPA and your NAPA. OPA is oropharyngeal airway. NAPA is nasopharyngeal airway. Of course, there are also OPA, OMA, ONA, UNI, AJUSHI, but they are not necessary. Use your OPA and NAPA if you think the airway is compromised. If there is abnormal breathing, stridor or giggling sound, or loads of secretion. Remember, don't use oropharyngeal airway if there is gag reflex, otherwise the patient will vomit and there's risk of aspiration. For nasopharyngeal airway, be careful if you think there is base of skull fracture. You can measure OPA from the mid-incisor to the angle of mandible, or from the edge of the mouth to the ear tragus. While measurement of nasopharyngeal airway is from the edge of the nose to the tragus. L stands for the laryngoscope and blades. They are used to visualize the vocal cords to facilitate intubation. Also useful in the insertion of gastric tube or even TOE probe. The handles are usually standard sized. There are various types of blades. The most common ones are Macintosh and Miller. Macintosh blade attaches to handle at 90 degrees, while Miller and Wisconsin blades, the straight blades with curved tips. The others like McCoy, it is Macintosh-like blade with movable distal tip, and McGill, straight blade with U-shaped cross-section. S stands for a lot of things: stylet, suction, syringe, stethoscope, self, staff, even spender. Get the stylet and insert it into your ET tube. Next is your Yonker suction. Insert it below patient's right shoulder. It has to be easily accessible during intubation. Next is your syringe. It is very important to inflate the pilot's balloon so that the ET tube does not become dislodged. And of course, your stethoscope for confirmation of the placement. The rest are like yourself, your own self. You have to be highly trained, and also your staffs. And lastly, spender. Why spender? Because sometimes you cannot intubate, cannot ventilate. You'll be sweating like there's no tomorrow. And an extra spender would be handy for managing the next patient.